I just wanted to reconvene the ACIP session. Thanks everyone for giving us a 1-minute break. And we're going to start with Dr. Brooks, who will provide, he's chair of our ACIP polio vaccine work group. He will provide an introduction and overview of today's session.
All right. Thank you very much, Chairman Lee. So polio work group was formed about a year ago, maybe a year and a half ago, for reasons of which you all are aware. And these posted here are the terms of reference, policy topics under consideration. So first, whether more specific guidelines of adult vaccination, including the use of adult booster doses, can be provided in the context of circulating polio virus, which is obviously the key issue. Whether adults are immunocompromised should be recommended an additional adult booster of a polio-containing vaccine, whether fractional doses of IPV as pre-qualified by the World Health Organization should meet polio vaccination requirements, including for people immigrating to the U.S., and consider criteria on which novel oral polio vaccine type 2 might be used in areas with outbreaks or persistent circulation of the polio virus. So at this point, we will be discussing and evaluating and voting on number one term of reference. So with that, next slide, I turn it over to Dr. Kidd, our fearless leader of the work group.
Thank you, Dr. Brooks. So next slide. Good afternoon, everyone. Today I'll be presenting on behalf of the polio vaccination work group. There are two main objectives for today's presentation. First, I'll summarize the polio work group deliberations on adult polio vaccination, specifically for recommendations for unvaccinated and incompletely vaccinated adults, and recommendations for booster doses of IPV. And then I'll present the work group's proposed language for an ACIP vote later this afternoon. Next slide. I'll be presenting the workgroup deliberations using the ACIP evidence to recommendations framework that you're familiar with, and according to the ETR domains listed here. Next slide. As background, the most recent ACIP statement on adult polio vaccination was published in 2000, and it contains some ambiguous and outdated language. The 2000 statement states that vaccination is recommended for certain adults who are at greater risk for exposure to polioviruses than the general population. Unvaccinated adults who are at increased risk of exposure should receive a primary vaccination series with IPV, and adults who have had a primary series of oral polio vaccine or IPV and who are at increased risk of exposure can receive another dose of IPV. Next slide. Multiple problems and questions about the recommendations came to light last year when the New York paralytic polio case was identified. First, the 2000 statement focuses almost exclusively on adults at increased risk of poliovirus exposure. And it was unclear how increased risk should be defined in the setting of circulating vaccine-derived poliovirus in the United States. In addition, there was no clear guidance for unvaccinated adults who were not known to be at increased risk of exposure. And there was uncertainty about vaccinated adults and when and if a booster was advised. Next slide. So the first policy question the work group addressed was, should completion of a primary polio vaccination series with IPV be recommended for unvaccinated and incompletely vaccinated adults in the US? To be more precise, the population of interest was unvaccinated and incompletely vaccinated US adults aged 18 or over. The intervention is completion of a primary vaccination series with IPV. The comparison group is no vaccination or partial series completion. And the most important outcomes of interest were prevention of paralytic polio, serologic immunity to polioviruses types 1, 2, and 3, serious adverse events following vaccination, and then also indirect effects such as community transmission and impact on health systems. Next slide. And just to keep in mind, the current definition of fully vaccinated, an adult is considered fully vaccinated against polio if they received a primary series of at least 3 doses of trivalent OPV or IPV in any combination administered at least 4 weeks apart, and the last dose in the series was given on or after the 4th birthday, and the last dose in the series was given at least 6 months after the previous dose. Next slide. As this group knows, poliovirus infection can cause poliomyelitis and lifelong paralysis. But paralytic disease occurs in fewer than 1% of infections, with the exact frequency varying by serotype. And most poliovirus infections are asymptomatic. Next slide. The incidence of paralytic polio decreased rapidly in the United States after introduction of the Salk inactivated polio vaccine, quickly followed by the Sabin oral polio vaccine. The Sabin oral vaccine was used for routine childhood immunization in the US for decades, and in 1997, an enhanced potency IPV was introduced as part of a sequential schedule with OPV. In 2000, the US moved to an IPV-only schedule, and IPV has been the only polio vaccine recommended in the US since that time. Next slide. Wild poliovirus type 1 and vaccine-derived polioviruses are still circulating in certain parts of the world. This figure shows the distribution of the almost 700 paralytic polio cases that have been identified in the last 12 months. Of note, environmental detections, for instance from wastewater, are not shown in this figure. Next slide. And then, as you are aware, a case of paralytic polio caused by vaccine-derived poliovirus type 2 was confirmed in an unvaccinated young adult from Rockland County, New York, in July last year. Genetic sequencing has indicated a linkage to polioviruses collected in wastewater in Israel, the United Kingdom, and Canada. And of note, Rockland County has reported overall low vaccine coverage for over 20 years now. In the summer of 2022, just 60% of children under age 2 had received 3 doses of IPV, but zip code level coverage was as low as 37% in some areas. Fortunately, no additional paralytic cases have been identified. Next slide. Poliovirus related to the case was detected in wastewater and several other New York counties and New York City. Retrospective testing detected poliovirus in the area as early as April 2022, indicating circulation and asymptomatic infections in the area at least since that time. Related virus continued to consistently be detected in wastewater until the beginning of November last year. Only 2 samples have been positive for poliovirus since November 1st, with the most recent being collected on February 22nd in Rockland County. Samples collected in the last 15 weeks have all been negative. Next slide. This figure shows the pattern of wastewater detections in each affected county by week, with poliovirus detections depicted in red and negative poliovirus samples in blue. And to reiterate, there was just 1 paralytic polio case identified, but the presence of that case and the pattern of wastewater detections indicate that there were likely at least 1,000 to 2,000, mostly asymptomatic infections in the area. Next slide. Circulating poliovirus poses a risk of paralytic polio to those who do not have immunity, and in the United States, most people are protected from paralytic polio because they've been vaccinated. National Salk IPV vaccination campaigns in the late 1950s targeted all persons up to the age of 40 years. This table shows national household survey data for Salk IPV vaccination coverage by September 1961 by age and race. In general, campaign coverage was highest among children who are aged 5 to 14 years in 1961, so this would be birth years 1947 to 1956. Also of note, estimates of coverage were higher among whites than non-whites in all age groups. Next slide. In comparison to children and adolescents, coverage was lower in adults aged 20 and older, and not many adults 40 or over were vaccinated in the campaigns. Next slide. After that particular household survey, subsequent surveys focused on coverage among preschool-aged children. This figure shows data from 3 different national surveys for 3-dose polio vaccination coverage among children. I want to note that these are different surveys which use different methodologies and have different limitations. In particular, the first survey, USIS, was based on parental recall and is thought to underestimate actual coverage by as much as 20% when it was compared to actual vaccination records. In contrast, the National Immunization Survey, or NIS data, come from actual vaccination records. So while coverage levels here, especially in the 70s and 80s, might be cause for concern, if you go to the next slide, it's interesting to contrast those coverage data with serosurveys that indicate that a large majority of Americans have protective antibodies to poliovirus. In this enhanced survey that was conducted in 2009 to 2010, seroprevalence varied by poliovirus serotype, but was high in all the age groups studied. Seroprevalence for type 3 was consistently the lowest, but remained high even in the oldest age group. Next slide. Of note, there were some small differences in seropositivity by race ethnicity group, but none of these were statistically significant among the younger age groups. Next slide. Among older adults, differences by race ethnicity were generally not statistically significant either, with a few exceptions where Mexican-American adults had slightly lower seroprevalence of type 2 antibodies compared to non-Hispanic blacks in the 20 to 39-year age group, and compared to non-Hispanic whites in the 40 to 49-year age group. They also had lower levels of type 3 antibodies compared to non-Hispanic whites in the 40 to 49-year age group. Unfortunately, there are no seroprevalence data for older age groups by race ethnicity. So next slide. So to summarize the problem, the US remains at risk of poliovirus importations as long as there's ongoing transmission of poliovirus globally. Data indicate that most US adults have serologic immunity to polioviruses type 1, 2, and 3. However, unvaccinated and incompletely vaccinated adults remain susceptible to paralytic polio if exposed to poliovirus. Next slide. So in response to the question for the ETR domain, is paralytic polio a problem of public health importance? The work group agreed that yes, paralytic polio is a problem of public health importance. Next slide. The effectiveness of enhanced potency IPV has been established. The presence of detectable neutralizing antibodies is an accepted correlate of protection against paralytic disease. However, immunity against paralytic disease can be present even in the absence of detectable antibodies. Studies of the serologic immunogenicity among infants and children show that 70 to 100% are seropositive after 2 IPV doses, and 88 to 100% are seropositive after 3 doses. There are limited data on the vaccine effectiveness against paralytic polio, but estimates range from 36 to 89% for 1 dose and 89 to 98% for 2 doses. However, because this is a routine childhood vaccine, there's a paucity of data for previously unvaccinated adults who receive a primary series. Next slide. In addition to serologic immunity, which protects against severe disease and paralysis, it's also important to consider mucosal immunity and the potential effect of IPV on transmission. IPV does not decrease the proportion of people who will shed poliovirus when exposed. Multiple studies have shown that there is no significant difference between IPV and unvaccinated individuals in terms of the odds of shedding. However, several studies indicate that IPV may reduce the quantity and perhaps duration of shedding, although a recent modeling study indicated no impact of IPV. There are fewer data on nasopharyngeal immunity following IPV, but data from 2 studies suggest that rates of nasopharyngeal shedding are similar and low, 0 to 4%, among both OPV and IPV vaccinees. Next slide. In terms of safety, the safety of IPV is also well established and IPV is well tolerated. Local reactions at the injection site were reported during clinical trials, and up to 1/3 reported erythema, induration, or tenderness at the injection site. Combining IPV with other vaccines has not been associated with increased frequency or severity of reported adverse reactions compared to when the other vaccines are administered alone. And no serious adverse events have been causally associated with the use of the current formulation of IPV. Next slide. In a paper that looked at 2000 to 2012 data from the Vaccine Adverse Event Reporting System, during a period when more than 250 million IPV doses were distributed during 2000-2012, 41,792 adverse event reports were submitted for IPV-containing vaccines. Most of these were non-serious, and 95% were among persons less than 7 years of age. Most events were associated with IPV that was co-administered with other vaccines, and standalone IPV accounted for just 0.5% of reports. It is important to remember that VAERS is a passive reporting system and can't assess causal associations between vaccination and adverse events. However, the lack of signal in VAERS after decades of IPV use is reassuring. Next slide. Therefore, for the ETR domain of benefits and harms, the work group interpretation was that if you take into account both the individual and population level effects, the desirable anticipated effects of completing a polio vaccination series are large. Next slide. The undesirable anticipated effects are minimal. Next slide. And the anticipated benefits of completing a primary polio vaccination series outweigh the anticipated harms. Next slide. When thinking about population values, there was an Annenberg Science Knowledge Survey conducted in October last year that included questions about polio, so we actually have some data on what the general public thinks about polio recently. In this survey, 59% of people said that it would be extremely bad to have polio, and an additional 26% said it would be very bad to have polio. This was a higher proportion of the population than for other diseases surveyed, including long COVID, monkeypox or mpox, or measles. So there's evidence that the general public values polio prevention, at least at the individual level. In addition, 85% said they were likely to recommend that an eligible person in their household get vaccinated with the polio vaccine, indicating relatively high acceptability of the vaccine among the general public. Next slide. However, when thinking about the values of the specific population in question, which is unvaccinated or incompletely vaccinated adults, it's likely that this is a heterogeneous group that consists both of persons whose family chose for them to not be vaccinated as children and persons who missed opportunities to be vaccinated as children. And there's a lack of data on how these populations currently perceive their risk of paralytic polio and how they perceive the anticipated positive versus negative effects of polio vaccination. Next slide. Additional acceptability considerations include, of course, the context of global polio eradication efforts, and that the prevention of paralytic polio has been a public health priority for decades. But in practice, there are currently many competing priorities for clinicians and local public health departments, and uncertainty about who is eligible for vaccination, and outside of an outbreak setting, uncertainty about the true level of risk to adults in the US could also undermine acceptability. Next slide. So in response to the ETR question of whether the target population of unvaccinated or incompletely vaccinated adults feel that the desirable effects of vaccination are large relative to the undesirable effects, the work group thought that it likely varies because of the heterogeneity of this group. Next slide. And as reflected on the previous slide, the work group felt that there is probably important uncertainty or variability in the values of the target population. Next slide. In contrast, for acceptability of key stakeholders overall, the work group felt that providing a primary series to unvaccinated or incompletely vaccinated adult was probably acceptable to key stakeholders. And then moving on to feasibility and discussions. In terms of feasibility and potential supply and demand, there currently is just one US licensed manufacturer of standalone IPV. And there currently are 3 US licensed manufacturers of combination vaccines that include IPV. However, these combination vaccines are currently not indicated for adults. The potential demand for IPV is difficult to quantify. We don't have data on the number of adults who know they are unvaccinated or incompletely vaccinated, so it's difficult to quantify potential demand. Next slide. In practice, we can learn from New York's experience last summer. New York State and New York City did not experience any significant IPV supply issues despite identification of a polio case, persistent wastewater detections in the area, national media attention, and calls and a concerted effort by the health department to vaccinate unvaccinated persons, including adults. Next slide. Other resource and feasibility considerations include issues with access. Adult medicine offices typically don't stock IPV, so access to vaccination sites that do stock IPV could be a barrier to implementation. Also, there are concerns about potential effects on health systems and their vaccine screening and patient recall algorithms. But it was felt that these concerns could be mitigated with clear guidance for who is eligible for vaccination with these recommendations. And then finally, the work group talked at length about the feasibility of implementing risk-based recommendations, particularly if risk of exposure in the population changes over time. And I'll say more about this topic in a few slides. Next slide. But overall, the work group felt that vaccination of adults who are known or suspected to be unvaccinated or incompletely vaccinated was probably or was a reasonable and efficient allocation of resources. Next slide. They also felt that it was probably feasible to implement. And next slide. Sorry, the was probably feasible to implement and thought. Next, for the next domain of equity considerations, we know that there are different rates of childhood vaccination and poliovirus immunity in different communities, and that having an opportunity to receive catch-up polio vaccination as an adult likely increases equity. There are no known differences in vaccine effectiveness among immunocompetent persons in the US setting. And finally, assuring equitable access to vaccination sites with IPV will be an important consideration for implementation. Next slide. So overall, the work group felt that providing polio vaccination for adults known or suspected to be unvaccinated or incompletely vaccinated would probably increase equity. Next slide. For the overall balance of consequences, taking into account all of the ETR domains just presented, the work group considered two different populations of unvaccinated adults. For unvaccinated and incompletely vaccinated adults known to be at increased risk of poliovirus exposure, the work group's judgment was that the desirable consequences clearly outweigh undesirable consequences in both settings. Next slide. For unvaccinated or incompletely vaccinated adults who are not specifically known to be at increased risk of poliovirus exposure, the work group's judgment was that desirable consequences probably outweigh undesirable consequences in most settings. Next slide. Most of the work group deliberations were focused on whether the recommendations for unvaccinated adults should be a risk-based recommendation or a uniform recommendation for all unvaccinated adults. Currently, situations that are considered to put adults at increased risk of poliovirus exposure include international travelers, laboratory and healthcare workers, and healthcare workers or other caregivers. In addition, unvaccinated or incompletely vaccinated adults whose children will be receiving an oral polio vaccine, and unvaccinated adults or incompletely vaccinated adults who are living or working in a community where poliovirus is circulating are considered to be at increased risk of exposure, and vaccine is recommended. Next slide. It became clear to the work group that most of these situations posed risk at the individual level, and there would be an opportunity to anticipate the risk and vaccinate prior to the potential exposure. Next slide. But this last situation for unvaccinated and incompletely vaccinated adults in a community where poliovirus was circulating was a little bit different. This situation affects an entire population, and the community is already at increased risk at the time the risk is recognized. This means there would potentially be missed opportunities for vaccination prior to exposure if the recommendation remains solely a risk-based recommendation. Next slide. Additional challenges with the current risk-based recommendation came to light in 2022 as CDC and New York City and state health departments received numerous questions about which adults were at increased risk of exposure. For instance, in which of these counties with wastewater detections or adjacent to wastewater detections are unvaccinated adults considered at increased risk of exposure? Are counties with a single wastewater detection of poliovirus considered to be at increased risk of exposure? When are unvaccinated adults in these counties no longer at increased risk of exposure? And are unvaccinated adults traveling to these counties at increased risk of exposure? As wastewater surveillance becomes more common, it's possible that other jurisdictions might experience sporadic detections of poliovirus in their wastewater, and these are the types of challenges that come up when trying to implement a risk-based recommendation. Next slide. With these factors in mind, the pros of a uniform recommendation are that it allows unvaccinated adults and their healthcare providers to take advantage of opportunities to get vaccinated before they are at increased risk of exposure. It also brings adult polio vaccination policy closer in line with other routine child vaccines, such as MMR and varicella vaccines. And in addition, it's a less complicated policy to communicate and understand and implement, in that the recommendation doesn't change based on the latest wastewater data. Next slide. The cons are that most adults in the United States still have a low risk of poliovirus exposure and paralytic polio. And most adults received their primary polio vaccination series as children. The other con is that demand for IPV could potentially exceed supply, particularly if a large number of adults without documentation of polio vaccination status were to assume that they were not vaccinated. However, again, the group felt that this issue could be mitigated by providing guidance for this group in the clinical considerations. Next slide. Ultimately, the majority of the work group supported a uniform recommendation. However, a substantial minority favor the current risk-based recommendation with the addition of language specifically addressing unvaccinated adults who are not known to be at increased risk of exposure. So the majority proposed language is that adults who are known or suspected to be unvaccinated or incompletely vaccinated against polio should complete a primary vaccination series with IPV. Next slide. This language has to be taken in the context of who is or who should be considered unvaccinated in the clinical considerations. So the following is important context that will be included in the clinical considerations. In general, unless there are specific reasons to believe they were not vaccinated, most adults who are born and raised in the United States can assume they were vaccinated against polio as children. Polio vaccination has been part of the routine childhood immunization schedule for decades and is still part of the routine childhood immunization schedule. Adults who received any childhood vaccines almost certainly were vaccinated for polio. So next slide. Now I'm going to move on to the second policy question. Next slide. The second policy question addressed by the work group was, should a booster IPV dose be recommended for adults at increased risk of poliovirus exposure who have previously completed a primary polio vaccination series? Again, the specific population being considered is US adults aged 18 years or over who are at increased risk of poliovirus exposure and who have also completed a primary polio vaccination series with trivalent OPV, IPV, or a combination of both. The intervention is a booster dose of IPV, and the comparison group is adults who completed a primary series but did not receive a booster dose. Again, the main outcomes of interest were prevention of paralytic polio, serologic immunity to poliovirus types 1, 2, and 3, serious adverse events following vaccination, and then also indirect effects such as community transmission and impact on health systems. Next slide. The current recommendation regarding adult boosters is that adults who have had a primary series of OPV or IPV and who are at increased risk of exposure to poliovirus can receive another dose of IPV. Available data do not indicate the need for more than a single lifetime booster dose with IPV for adults. This has been a long-standing recommendation since trivalent OPV was used in routine immunization. However, the actual need for a supplementary dose has not been established, but it has been thought that there is value in assuring protection against infection with wild polioviruses when exposure can reasonably be expected. Of note, there were at least 2 reported cases of paralytic polio in adult travelers who had completed a primary series with either Salk IPV or trivalent OPV. However, further details on these cases are not available, and it's unknown whether a booster dose would have prevented these cases. Next slide. So this 2000 guidance was complicated in 2014 when CDC issued interim guidance in response to new WHO Polio International Health Regulations Emergency Committee temporary recommendations. These WHO recommendations were for travelers who were departing countries with poliovirus circulation in order to prevent exportation. And they applied to residents and also travelers who were staying in the country for more than 4 weeks. If implemented by a country, proof of polio vaccination within the last 12 months could be required prior to leaving the country. And this recommendation or a similar recommendation is still included in the most recent polio IHR statement. So in response to this new WHO recommendation in 2014, which differed from ACIP recommendations, CDC published interim guidance in 2014 that stated, as a precaution, persons aged 18 years or older who are traveling to areas where there has been wild poliovirus circulation in the last 12 months and who have received a routine series with either IPV or OPV in childhood should receive another dose of IPV before departure. Next slide. It's unclear whether previously vaccinated adults need an IPV booster for protection. Shown here again are the results of the INHANE serosurvey showing that the seroprevalence of neutralizing antibodies is high for all 3 serotypes and in all age groups studied. Next slide. There are no data on the comparative vaccine effectiveness of a primary series plus booster compared to a primary series alone, but serologic studies in adults with heterogeneous pre-booster vaccination histories and heterogeneous seropositivity have shown that 98 to 100% are seropositive 1 month after receiving an IPV-containing booster. One study also followed up trial participants 10 years later, and 98 to 100% were still seropositive at that time. Next slide. The safety of IPV was previously described in this presentation, but I'll point out again that combining IPV with other vaccines has not been associated with increased frequency or severity of reported adverse reactions compared with when other vaccines are administered alone, and no severe adverse events have been causally associated with the current formulation of IPV. Next slide. So for the ETR domain of benefits and harms, the work group determined that for adults at increased risk of exposure, the desirable anticipated effects of receiving an IPV booster were small to moderate. And next slide. The undesirable effects were minimal. And next slide. The anticipated benefits outweigh the anticipated harms. Next slide. Considering target population values, I'm showing you again the results of that Annenberg survey conducted last year that shows the majority of adults surveyed thought that having polio would be extremely bad or very bad, and that 85% said that they were likely to recommend that someone in their household get vaccinated against polio if they were eligible. Next slide. So the work group thought that the target population, meaning previously vaccinated adults who were at increased risk of exposure, probably felt that the desirable effects of a booster were large compared to the undesirable effects. However, this was split with a significant portion of the work group also saying that we don't know based on the limited data available. Next slide. But the work group thought there probably wasn't important uncertainty or variability in terms of target population values. Next slide. When considering acceptability, feasibility, and resources for IPV boosters, the work group noted that the current recommendation that adults who have had a primary series of OPV or IPV and who are at increased risk of exposure to poliovirus can receive another dose of IPV, that this recommendation is longstanding and is generally considered accepted, and feasible. However, if the at increased risk of exposure group were to be expanded, for instance, to include previously vaccinated adults in certain US areas with poliovirus circulation, feasibility might be affected in the future. And again, the experience of New York State and New York City in 2022 is helpful in that even in the context of a polio case and media attention, IPV with supply was not a significant issue. Next slide. So the work group agreed that providing a booster IPV dose to adults at increased risk of exposure probably was or was acceptable to key stakeholders. And next slide, that it probably was a reasonable and efficient allocation of resources. And next slide, and that it was also probably was or was feasible to implement. Next slide. Finally, to address the equity ETR domain, there are no known differences in response to a primary series or need for a booster by socioeconomic group in the US setting. And no groups or settings are known to be disadvantaged by the current recommendation. However, the work group thought that there is a potential for increased equity by boosting immunity in persons at increased risk of exposure, especially persons with potential occupational exposures to poliovirus. Next slide. So on that basis, overall, the work group thought that boosters for those at increased risk of exposure probably increased equity. Next slide. For the overall work group judgment, taking into account all of the ETR domains, the work group thought that the desirable consequences of an IPV booster probably outweigh the undesirable consequences in most settings for previously vaccinated adults who are at increased risk of poliovirus exposure. Next slide. So the majority of the work group agree with the current ACIP recommendation for adult boosters, and we're asking for a vote to reaffirm this language. This recommendation is risk-based and based on shared clinical decision-making, and the proposed language includes some slight edits to modernize the language compared to the 2000 statement. The proposed language is adults who have received a primary series of trivalent OPV or IPV in any combination and who are at increased risk of poliovirus exposure may receive another dose of IPV. Available data do not indicate the need for more than a single lifetime booster dose with IPV for adults. Next slide. For the clinical considerations, I'll just repeating the situations that put adults at increased risk of poliovirus exposure or examples that are given. These examples include travelers who are going to countries where polio is epidemic or endemic, laboratory and healthcare workers who handle specimens that might contain polioviruses, healthcare workers or other caregivers who have close contact with the person who could be infected with poliovirus. Next slide. So this concludes my presentation, and I'd like to thank the polio workgroup members for participating in these discussions and providing their valuable input. Next slide, thank you.
Thank you, Dr. Kidd. That was such a clear presentation, really appreciate it. This presentation is now open for questions and discussion. Dr. Paling.
So would you put the first language up for the first vote? There was two, reaffirming and then the first one. So first of all, I want to say, while you're doing that, I want to say thank you, Dr. Kidd, for a very clear and well-organized presentation. It was outstanding. And I think one of the points that you made is really important, that for every one case of paralytic polio, you probably have 999 asymptomatic cases. And so that ratio is really important. So can we get the language? Do you need me to say the slide number?
Stephanie, I'm sorry, my computer restarted, so I'm pulling up my slide deck right now so I can give you a slide number.
Okay. Thank you. That is exactly it. So I would like to make a motion to accept the wording on the slide. Thank you.
Thank you, Dr. Paling. Do I have a second? Dr. Talbot?
I second.
Thank you. It's been moved and seconded to accept the proposed language for unvaccinated and incompletely vaccinated adults as written on the slide here. Any additional comments? Dr. Cotton.
Just very briefly, it looks as though there really isn't much information to inform decision-making with immunocompromised patients, and it doesn't look as though there's any consideration for them, likely due to the lack of data, but I would just highlight that an estimated 3% of the U.S. population is immune compromised, and we should consider them and their risk, especially where they may be traveling after the onset of immune suppression, and so they may well remain vulnerable, and could actually be a major public health situation in that they may shed virus for a longer period of time, et cetera. So, thank you.
Thank you. Dr. Sanchez?
That was a very nice presentation, and I agree with the proposed language. I just wanted to comment on the clinical considerations. You kind of brought this up already, but I think individuals who are going to be taking care of children who've been recently vaccinated with oral polio may be another risk group. And you mentioned international adoptees. You put healthcare workers or other caregivers who could be infected with polio, but if they've recently received oral polio, I don't know if that's maybe another consideration.
Currently, the current guidance is that unvaccinated persons who might be in contact with shed OPV would be considered high risk, but that a booster would not necessarily be indicated in that situation.
No, I agree.
Okay, you approve. Okay.
Dr. Lear?
I take care of a large number of partially vaccinated or unvaccinated patients, so this is actually very relevant for my practice, and I appreciate the work group working on this. I also want to comment that it is in my experience that when people decide to vaccinate, polio is almost always the first vaccine they choose to do. And so I think you're quite right that if you've ever had any childhood vaccines, you probably got polio, because it's such a scary disease and such a boring, safe vaccine. So I think that's very reasonable approach, that if you've ever had any childhood vaccines, you probably got polio.
Thank you. And for the record, we don't think vaccines are boring. Dr. Paling?
All right, would you mind pulling up the second vote language? Okay, and so as I understand this, Dr. Kidd, this is a reaffirming, using more modern language, the recommendation that exists.
Correct, and it's also just clarifying what ACIP recommends in the context of the 2014, the WHO recommendations and wording that has been in effect since 2014.
Okay. Fantastic. I would like to make a motion to accept this recommendation as worded.
Thank you, Dr. Paling. Do we have a motion on the table? Would anybody like to second? Dr. Sneas?
I would like to second that motion.
Thank you. It's been moved and seconded that we accept the current wording on the slide for vote number 2 for polio vaccines. Any other? Oh, Dr. Cotton?
I would like to just comment that we don't know that a single lifetime booster dose with IPV for adults is appropriate for immune compromised. That data is not known. I would not amend this, but we don't know that to be true. It often is not true for immune compromised.
Any other questions or comments? Oh, I see. Dr. Juthani.
Thank you. Representing Association of State and Territorial Health Officials. So when in the next slide on this, where you identified what would be identified as potential risk of poliovirus exposure, there is no reference specifically to the type of incident we had most recently in terms of vaccine-derived strains. And so I wanted to know if there was any sort of thought on clinical considerations that could help providers in communities where they may have vaccinated people, particularly older adults. This came up for a lot of people in terms of assessing risk for them, given that they probably were vaccinated a very long time ago. Thank you.
Yeah, that's a challenging question and something the work group has brought up and discussed. First of all, this this applies to all polioviruses, so whether it's a wild strain or vaccine-derived poliovirus, so just to clarify that. In terms of recommendations for if there is a case of polio detected in the United States or wastewater detections, I think it's challenging to give standard or universal recommendations at this point. I think we would have to work with the health department based on the pattern of detections and the type of virus, whether it was Sabin-like or had enough changes that it was vaccine-derived to make a call of recommendations for boosters at this time. I think the the benefit of moving to a uniform recommendation for unvaccinated adults is that there's a clear uniform recommendation for unvaccinated adults. There's clarity of that. We don't have to split hairs about what is increased risk for those people or not. Go ahead and get those vaccinated. But in terms of when boosters might be recommended is, I think, something we'll have to work with health departments and what happens, what the specific situation entails.
Dr. Good?
So just a point of clarification is that in the 2000 recommendations, there were 3 statements. So these 2 statements would replace those 3 statements?
Can you go to the previous slide, please? There's 2 statements in the 2000. The second sentence is identical or virtually identical. The main change in the first statement is it's replacing a can with a may, and I think it describes the primary series in more detail, primary series of trivalent OPV or IPV in any combination.
I don't see any other hands raised in the room or on the chat. So, did I miss? Dr. Paling. I always miss this side.
Yeah, I do want to just clarify that in the United States, we give IPV as a childhood vaccine. So if there's an exposure to OPV, there should be travel associated with that because we are not giving, and I want to make sure that I'm speaking correctly, Dr. Kidd.
You're correct that, yes, IPV is the only polio vaccine approved in the U.S. since 2000. Mm-hmm.
Thank you. So with that, we will close this session. Thank you, Dr. Brooks and Dr. Kidd, for catching us up and allowing us to be on time. We really appreciate it. We'll take a 15-minute break and return at 30 minutes after the hour for influenza. Thanks to our speakers.